We're going to finish with this clinical burnout, the 2017 update. This was written by Ramin Tabatabai, who's a resident that Jan and I both have trained and works with Jan now in the residency office. Physician burnout is a pretty important topic, and there's some kind of unusual things about emergency medicine that I think are kind of worth discussing and knowing. And so how do you measure burnout? It's like many psychiatric and psychometric testing kinds of things. There's no great way to measure it. Probably the most accepted is this 5 or 6 page thing called the Maslach Burnout Inventory. When LA County USC, when I was the program director way back when, and we ran the ACEP wellness booth, we started doing Maslach burnout inventories on docs and advanced practice providers who were there. And so we created a pretty large database. What we learned about doing this, and I don't love the Maslach burnout inventory. If I was to give you one right now in front of you, you'd be like, yeah, this is going to overestimate. Because if I am truthful about a lot of these answers, I'm going to sound like some charcoal briquette, self-starting Kingsford, don't light a match around me kind of thing. And so I think that the Maslach burnout inventory, if you were to look at it with sort of a skeptic's eye, you might feel there was a lot of leading of the witness as you sort of go through it. Like, yeah, they're trying to convince me I'm burned out. I'm a third of the way through the survey and I'm feeling more burned out every minute. But it is a validated tool. One of the things that came out when we looked at the Maslach burnout inventory was just how early in careers it seemed to start. So it starts really early in training and early in residency. And in some ways that kind of makes sense, right? When people are in residency and new grads, they're in a really dynamic part of their life. They're trying to make enough money for a mortgage. They're often having their children. Many of them are newly married. They're, transiting into a professional world that has a bunch of stresses in it. Oftentimes they're working harder. I know lots of people who have done 20 shifts a month for the first couple of years because they're trying to get a down payment together. So all of that stuff is contributing to what is evidence of burnout really early in careers. And so anyway, so we're going to talk a little bit more about the burnout inventory as we get into this chapter. There is a separate section on this, the first few articles, which are about physician suicide, and I'm going to deal with that first. I don't know how closely physician suicide correlates with burnout. We do know that it correlates well with major psychiatric diagnosis, major depressive illness, bipolar disorder. Those do. And so let's look at some of those papers. We got a couple of papers here. The first paper compares mortality rates and causes among U.S. physicians and finds that there's a higher rate of suicide than you might expect in physicians. Abstract 2 looks at physicians with some of these problems and describes some of the features of docs with major depressive disorder and bipolar disorder. And they find some disturbing things in there which residency offices and medical staff offices have become very alert to. What they find is that in docs who have major depressive illness, they often are having medical staff and interpersonal communication problems. They often are not seeking mental health help. They don't go to psychiatrists often. They self-prescribe a lot. They might have put themselves on an antidepressant. We find that frequently in this group. They're worried about stigmatization. They worry about who to trust. You might imagine yourself, and I've been in this position as a program director, someone comes to you saying they're having depression and maybe some suicidal thoughts. Of course, you're going to refer them. You don't want to be managing that as their program director. They're going to get prompt referral. The ACGME has mandated referral accesses almost as an institutional requirement. And so almost every residency program now has an immediate referral sort of source. But there's already immediate conflict starting there if you're the program director and they've come to you, and this is, you can see where the stigmatization comes in. As a program director, you're going to be asked when this person graduates and wants to be credentialed somewhere, are they mentally fit for the job? So the residents who might be depressed and people in those situations already have a reason to avoid talking to their PD about it, because it may the same way if you had some drug-related problem or a DUI, those things follow you. And so you can see where this stigmatization, judgmental, lasting career implications come from fessing up to having depression or needing antidepressants and things like that. And so that's why you see in abstract 2 that docs who are depressed, they seek low rates of treatment and referral to psych. They often end up with job performance problems. When their job gets in trouble, they often reach a really critical place, because you can imagine, pretty easy to imagine, all of us in healthcare have invested a large amount of time, energy, and money in becoming the healthcare providers we are. And when you face the loss of that, also, you often face the loss of your identity. When you ask other people what they do for a living, yeah, I drive a trash truck for the county. They don't say, I'm a trash man. But when you ask doctors what they do, and advanced practice providers what they do, they say, I'm a doctor. Their identity is tied to their work. Their being and self is about being a care provider. And so when they lose that, when they started getting in trouble with the medical staff office or losing privileges or having things like that, it's not just a threat to their employment. That's a huge threat, don't get me wrong. That's a huge threat. But it's also a threat to their identity as a person, because they self-actualize and self-identify with their careers. And so depression among docs is a really kind of a challenging scenario where, one, the loss of income and loss of job and medical staff office problems that are beginning to haunt them are made worse if they fess up that they're depressed, because now they're going to be stigmatized, their credentialing, they're going to have to answer and write letters to this, and so it becomes a really big issue. Abstract 3 looks at depression in docs. It's a survey with a shitty response rate, so it's hardly science, only 23% response rate. But it said about 11% of the responders, who knows whether they were over-selected when there's only a 23% response rate, but they noted that 11% with depression-related issues, they noted that work issues often develop. There was more self-treatment. Again, they avoided treatment because of confidentiality concerns and other things, and there was risk of stigmatization. So this is why depression is a real challenge among clinicians of all types, because they identify with it, they're worried about stigmatization, and they're worried about limitations of their privileges, probably with good reason. What are the suicide solution rates for docs? I don't want to get into this too much, but they suggest education and destigmatization. I don't know how that's going to happen. The education may be there. Certainly residencies are placing much more education and emphasis on this, and more stuff on wellness. There are now much better vehicles for getting help without going through a program director, and I think those are important. That might help. There's a lot of emphasis on them avoiding self-treatment with antipsychotics and with depression-type meds. And then they suggest targeting high-risk groups. I don't know how you find those groups. You know, I certainly have seen suicide as a program director and dealt with some of these issues, and it really is, you know, when it happens, it really destabilizes not just the family and friends around that, but the whole group, the whole residency group, even for a couple of years either side, are shook by this when it happens. So it is something that we absolutely need to be well aware of. On page 3, there's some resources listed, and there's, you know, an American Foundation for Suicide Prevention and some of these other things that talk about how to go about doing this. I don't think we have perfect answers for any of this yet. And it's hard to pry. My perception as a program director when I was a residency director, and it would be my perception as a chair, is I believe in sort of a limited role for that person. Obviously, they have a very important role in your professional development and stuff, but I'm not interested really in prying in what's going on in their private lives. And you'll hear very different approaches from other residency directors that really see themselves as having a whole picture and a view of their private lives and what's going on with their residents, and a much more sort of invasive approach to that. Some program directors have different feelings about that. I believe in a much more limited thing. Yes, if you're unprofessional at work, it's my business. If you're having job performance issues, that's my business as your program director. If you're having educational failings, that's my business as your program director. And I have, though I believe in that limited thing, had to have several discussions with residents over the years where I had to say, hey, listen, I don't know about this except from chatter in the department, and I'm certainly not talking to you in a formal way, but sort of off the record, blank, whatever it is, has to stop. Because if I'm hearing about it, it's too close to home. So this is, you know, in sort of an unofficial communique. All right, let's go more specifically into burnout, and you have this page here on page 4, I think is really worth looking at. They have that chart. So the dark bar, it's written in microscopic print. That's a measure of my age. I can't read that shit anymore. But the dark bar is the average for all specialties for burnout. And if you use a validated tool like the Maslach Burnout Inventory, where does emergency medicine lie? And it's not good news. We're at the top of that chart. We're the largest bar, yes. Oh, they're so stressed. It's which vacation home to buy. You know, the damn Nighthawk is stressing them out with bad reads. It's a very rough job. I'm just making fun. I know some of you know or love radiologists. I'm just making fun. But anyway, so there you see emergency medicine. Now that might sound like horrible news for us, and I don't think it's good news. But there's an important rival bar graph that we could draw, and that bar graph would have job satisfaction on it. Just overall job satisfaction. And here's the interesting thing about emergency medicine. This has been looked at multiple times. The same result has been found over and over again. We're near the top of burnout. We're also near the top in job satisfaction. That's very, very interesting about emergency medicine. We are literally 2 standard deviations out on both. When you compare it to a scatter diagram of other professions, we have very high job satisfaction and high burnout. This, to me, really points at some of the important things that we might intuit that we've already talked about a little bit about our practices, which is that when you're practicing in an emergency medicine environment, whether you're an APP or whether you're a nurse or whether you're an ER doc, that yes, you need to protect yourself from that profession. You need to do enough of it and stay active so you're good, but you can't let it eat you alive. And so if you're overworking, and again, I don't know what the number is for how many shifts is over the top, but I certainly know lots of my colleagues who, particularly early in their career when they had loans due and wanted to get a mortgage, I know a kid who worked 25 shifts a month for 3 years to pay off his loans, and he was a very good doc. He was a very smart kid, and man, was he fried. And he just felt for him and his personal values, he had to get those loans gone and get into the housing market. And it really drove him, and I think it was to his detriment. He's retired now. I'm not. He's retired now, but partly because he was so burned out. I don't know if he ever recovered from this. So, and this is a complex thing. Like, I think it's criminal that the average graduate of of residency now is $250K in the hole. That's the average. I know lots of people in training who are $300K in the hole. And so that's part of this stress that feeds in. I think debt is a big feature. It means you have to be really careful about what you do with moonlighting dollars when you're a resident and when you're a young doc. We used to think of it, when I was a resident, we thought of all possible purchases in international moonlighting units. An IMU back then, I'm old, but an IMU back then was about $700. And so you could say, I want an ocean kayak. It's 1.5 IMUs. I can have a really good one. But it's one and done. As opposed to a mortgage or a Porsche payment or a boat payment that forces you to keep moonlighting even if you need to take a break. And so down those other pathways lead to higher shift counts than probably are good for you and things that lead to burnout. So we'll get into this a little bit more. What do we know about burnout? What causes burnout? It's not single factor, but here's some of the things. Too much clinical work and too much nights. We know that does. Interestingly, all nights is better than scattered nights. We know that if you're a nocturnist, it's better. When we looked at our data from ACEP, and we didn't publish this, so this is unpublished data for you, but we looked pretty careful. The statistics weren't perfect, but I'll tell you how it panned out. There seemed to be a breaking point at around 5 or 6 nights. That if you're doing a full schedule, 14, 15, 16 shifts a month, as soon as you mix in more than 5 nights into that per month, there seemed to be a little jump in their MASLAC burnout inventory scores. It's just too hard to recover from. You can't scatter in 6 nights in a month's full schedule. You can do all nights. There's a very important paper, it's not here in this chapter, it's called A Rational Approach to Shift Work. It is in the EMA database that talks about all the things that we could do better about scheduling. Last year in this course, I did a whole chapter on circadian rhythm disruption and things we can do about circadian rhythm disruption in terms of casino scheduling, phase-forward scheduling, core sleep preservation scheduling, all kinds of things that we can do that we have been, I think, given that we're 45 years into our specialties development, I think we've been pretty slow to figure this out. We need to do better on those practical things. For example, as I mentioned earlier, Stony Brook, the night shift ends at 8. That's a colossal fuck up. You can't take a person at the end of a night shift when they got like 3 sane neurons left in them and have the ED get busy on them. They're not ready for that. Not to mention the fact that from a circadian rhythm standpoint, it's much better to send that person home before the sun comes up because the full facial sun on the way home resets your clock and destroys your ability to, you're exhausted at work. I've actually fallen asleep on a medical student presenting to me. I'm not going to lie to you. I have. I have actually had to have imagine the poor medical student. Dr. Mallon. Jesus Christ. Jesus Christ. I'm so interested in your education. Terrible. And then I get home and I can't sleep. Why? Because I had 15 minutes of full spectrum sunlight in my face on the way home. So we can fix that by changing shift at 6. Particularly during the winter months, it'd make a huge difference. We could do casino shift. Do you know what I mean by phase forward shifting? So you do days, 2 to 3 days in a row, then you go to evenings, you do 1 or 2 evenings, and then you end with a night. So that the time between shifts keeps getting longer and you keep shifting towards the night, and then after the night, or 2 nights if it's that, or 3 nights if it's that, you get a couple of days off. And so phase forward shifting, very difficult to do in an academic setting because you have daily meetings, you have rounds, you have things like that. So they start, many residents in emergency medicine start with a shift schedule that's not favorable. Many residents are doing 18 shifts, mixed in nights, rounds on days, research meetings, journal club. And so by the time the 3 or 4 years is over, they're already torched. They're already torched. So back to what causes it. We said to excess clinical load, nights certainly seems to have a breaking point around 5, 6 per month. Under-resourced area where you don't have scribes, the volume's too high, all of those things. Poor backup really stresses people. Excess transfers, all of those clinical elements that make for a bad ED are stressful. Lack of job security. I always tell people there is no such thing as job security in emergency medicine. You could be the leader of your group. Your group could have been stable in that hospital for 20 years, and what happens? Another company buys the hospital or the group. You're out of a job. I know a guy, because he worked with me, he was my vice president when I was president at Cal ASAP, who was the head of his group. He had been in there for 25 years, kids in school, house, mortgage, the whole thing, everything stable as can be. This is a true story, I'm not making this up. In the middle of a shift, he's working with a PA, grrr, 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 the fax machine goes off. This is Friday at 7 o'clock at night. The PA grabs the fax. The PA walks over to him and says, "Did you know that on Friday we're out of a job?" Next Friday, meaning. And he was like, "No, this is the leader of the group. First he heard of it, fax, 7 p.m. at night, you're out of a job in a week." And so I have always said that emergency medicine is a little bit like waiting tables. If you're good at it, you can always get another job, but there's no such thing as job stability. We do our best, and jobs, not having that job stability, the fact, we used to call these kind of contract assaults where someone swept in and got your contract in California. We still refer to it sometimes this way as a drive-by shooting on the contract, and they still happen. What protects you from burnout? This has been looked at. So teaching, working with younger docs and PAs in training and learning new stuff and teaching other people, working in an international environment where you get to teach some ultrasound or teach some critical care. All of those teaching roles, even teaching ACLS, not that we love ACLS or ATLS, even teaching in those roles, having a teaching role has recurrently been shown to be good. Having any other role in your specialty group, whether it's the QA person, whether it's the transfer coordinator, whether it's the EMS coordinator, having another role where you have some leadership and ownership stake and control and contribute to your group is really helpful. Having a role in the organized medicine, if that's your gig. If you want to be involved in AEM or Cal-ASEP or one of those things and get into leadership on that, or have an ongoing role in that. Having a role in developing a fellowship of some type. Having a role in your hospital medical staff or your sepsis board or whatever it is. All of those things are things that help people compensate and feel more engaged in their work. Just moving the meat, as we say. You know, going to work 18 shifts a month and moving the meat appears, if that's all you do, to be a little bit of a burnout-prone existence. And so since many of us have that existence, what all this is a reminder to you to protect yourself, to think about other things you can do. One thing that's not looked at in the American literature, but I'm very big on, I don't care whether you're a community doc or whether you're an academic doc. I believe, this is just me talking, but I think if we were a specialty, we would do this. I believe that for every year of work, of service you've had at your place, you should get a month toward a sabbatical. So at the time you've been there 3 years, you're owed 3 months, and maybe it will peak up, maybe it'll finish off at 6, but the group ought to have a plan for what to do. If someone goes for 3 months, this ought not destabilize the scheduling and tax other people. You should have a rational way that's, and I think, because I've taken a sabbatical and I've taken a break between academic jobs as well, 3 months is just long enough to be a real break. 6 months is ideal. A year is a little too long. That's my own, having done all versions of these sabbaticals, and I'm not pretending that my psyche is yours. God be it, if that was you'd in real trouble. But I can say with some experience that somewhere between 3 and 6 months is a great length for a sabbatical. I think that whether you're a community group, if you work for a community group, you ought to sit down and say, wouldn't it be great if we all got some little sabbatical time here and there where we might do some CME? Or maybe you'll just go to a Caribbean island and learn to paint. I'm not going to pretend that these sabbaticals have to be academic or career productive. You need a break. You need real breaks. And I think that they contribute to long-term, although it's not answered here in the literature. 8 talks about staff perceptions of our work environment, 31 studies. And how many of you work in an ER that's chronically short-staffed for nurses? Do we all? All of us, right? We have done as a specialty such a shitty job of nurse recruitment and retention. What is our problem with this? I mean, I know sometimes the nursing column is completely separate from the doc column, but I think we got to look at this. We've talked about this at places like LA County. How do we get our APPs to come to rounds and engage them so that they feel that they're in an academic community rather than just having them cover the ED while the residents are in their learning environment? Maybe we should be doing this with our nursing staff. What are the nursing careers that we need to grow up? Maybe we need to pay a lot of attention to make sure we have multiple senior, not just nurse manager items, but a mobile intensive care nurse position that's in the EMS office that might be shared or by 2 people, or a research coordinating nurse position that we grow up in through the nursing environment in our hospital. Whatever it is, we need to have more room for vertical advancement in all of the people who work with us so that we can retain them and keep adequate staffing. Autonomy in the workplace. Many of the nurses complain that they don't have the autonomy to do the decision-making that reflects their training and expertise, that we want them to do gut work. And that impacts their satisfaction. That impacts our relationships with them and makes the whole work environment crappy when everyone's feeling bad about going to work because they hate it. Unfortunately, there's very few intervention studies that have looked at whether fixing the things I'm talking about in a creative way produce a better work environment and better retention. I think it's a shame that 50 years into emergency medicine, we don't know the answers to those questions. I think we should, but we don't. What else do we got here? Evidence-based prevention of burnout. What do we know about this? We don't know that much about it. There's been a lot of focus on resiliency as a possible antidote to burnout. And so a lot of places have developed things like wellness committees, early education, self-care promotion, and stress relief skills, this sort of healthy life balance thing. We often like to say in emergency medicine, we work hard and therefore we play hard, but even sometimes our play hard habits are bad. I know for a lot of residents what play hard means is during my few days off, I'm hammered and partying all night long. That's not exactly getting it done in terms of a wellness strategy. And so having focuses on, we're going to have a round robin tennis thing where everyone can play tennis regularly, or we're going to have a Scrabble club, or whatever it is, there needs to be some more adapt. We're going to have a rotating barbecue thing where instead of getting hammered, we're going to focus on some fine wines with grilled food or something like that, where you start building strength in community, strength in terms of the way you relax, whether there's good exercise components and things like that. Abstract 10 from Lancet said you could decrease burnout with two approaches. A individual strategy where you talk about people about their lifestyles, their work balance, their shift schedule, all those kinds of things. I really think that's the most productive. But they also focused in this abstract on some organizational things you can do. And some of the organizational things that come to mind are things I've already addressed. Organizationally, you could integrate a sabbatical rule into your group. Organizationally, you could say no nights after 50 to 55. But if you're going to protect the oldsters from the nights, you also have to reimburse the nights better for the younger people. And I think 1.1, I've already offered this up, 1.1, which is the federal standard for the rate you would reimburse nights, I think that's bullshit. It should be 1.2 minimum. Next, we have to be smart about how we define nights and weekends and holidays. And I think the definition of what is a night, a weekend, and a holiday ought to be smart and generous. Smart and generous. For example, not that I'm here to drain my own personal abscess, but I work a lot of these shifts at Stony Brook that go from 5 to 2. That means I leave at 3. That means I get home at 3:30. That means I have a glass of wine at 4, and the fucking sun's coming up. That is not an evening shift, my friend. That's a night shift. If I get home and the stars are up and the sun's threatening to come up, it's Little Company of Mary. I worked there for years. I had these shifts that ended at weekend shifts. They had this weekend shift, 6 to 3. It's an evening shift. Bullshit. Ends at 3. You get out of there at 3:30, quarter of 4, home at a little before 5. That's not an evening shift. So here's my own personal beliefs on this. Any shift that ends after 11 should be paid as a night shift for the hours past that, because evenings end at 11. Any shift from Friday at 5 o'clock till Monday morning is a weekend shift. And if Monday's a holiday, then that's a holiday and a weekend shift. And we should be careful about this and be rational about it. And I think those are systemic things. We already talked about lengths of shifts. 12 hours, I work 12, I work 24s. How many people here are still working 12s and 24s? So, and the more rural you are, a lot of people love them, right? 6 24s is a full month. And that works if the volume's low enough that you're sleeping 4 to 5 hours out of 24. It doesn't work if you're up for 24. And 12s hurt a lot in a busy place. There's just no question. I can't do 12s anymore. I'm still asked to do 12s in our immediate care. Well, I did a 12 a day or two before I came here. A 12 in immediate care for me, where you're seeing about 3 an hour with a resident, sometimes with a scribe, but usually not. It's, at the last 2 hours of the shift lasts 36 hours, I'm sure of it. I check my watch, but something happens during the last 2 hours. It lasts at least 36 hours. I can't do it. I shouldn't be doing it. Abstract 11 is Gloria Kuhn, another survey that talks about how people in emergency medicine need to have tolerance of uncertainty, right? One of the things that stress people is they're not as sure, they worry I missed something. Emergency medicine there's a lot of risk tolerance that needs to be required. I've always said, show me an A+ medical student, and I'll show you someone who doesn't belong in emergency medicine. Doesn't belong in emergency medicine. Because the only reason they're an A+ student is because when given material to learn and facing the uncertainty of a test, they learned it all. Now, they had to be super smart to do that, but they had to learn it all. No emergency physician, no one suitable for emergency medicine would do that, because here's what we know about tests for the most of us in the room. That if you study for 10 hours, you get a P+. You study another 10 hours, your grade goes from 85 to 88. You study another 10 hours, your grade goes from 88 to 90. You study another 10 hours, your grade goes up to 90. No, almost any real emergency physician or anyone suitable for emergency medicine, somewhere between 10 and 20 hours says, fuck it, the B is good enough. I'm not doing that, because they're just not going to do that. And so emergency medicine is a place where there's a lot of clinical uncertainty, where you have to deal with that and manage that. It doesn't matter how much you know, that uncertainty is not going to go away. There's a lot of common sense and a lot of interpersonal skills that go with it. But tolerance of uncertainty is an important part of doing well in emergency medicine. Some people, when they look at these survivors in emergency medicine, have tried to describe a group, because there clearly is a group. We see it in these courses. You can see it at ASAP. You'll see people who've been doing emergency medicine for 35 years, not phased, look healthy, look good, doing great. And when you ask them about it, it's kind of an interesting thing. One, there clearly is a survivor group that does well. And that, by the way, is shown in the burnout data. So burnout is high in the first few years among a bunch of people, and then it goes down. We're going to talk about attrition rates in a moment. Attrition is high also. In the early years post-residency, attrition is higher than later. You would think, no, attrition is something that happens later in career. No. If you're at high risk for attrition, it becomes defined fairly early in your emergency medicine career that you're like, I need to get out of this. I need to take a new approach. And that's either because you're not comfortable with uncertainty, or you're not comfortable with the work environment, you're not comfortable with the nights, whatever it is, you've realized it's adverse for you, so there's a higher attrition earlier on than later. And in the survivor group, it's interesting because attrition drops to a rate lower than for other specialties. So let's deal with attrition right now. So it was said that because of the high burnout, emergency medicine had higher attrition than other specialties. Lots of people were leaving the practice of emergency medicine. Now, let's talk about the attrition rate for all specialties. We know the numbers. It's around 2.5% to 3% across all specialties. 2.5% to 3% of the practitioners retire or leave that practice per year. That's sort of the baseline across all specialties. It turns out that in emergency medicine, actually, our attrition rate is lower than other specialties. We didn't have good data. It was high in the very beginning, but that was a lot of people who were not trained to do emergency medicine leaving emergency medicine. So if you measured attrition in the 70s and 80s, it seemed to be high, but that was a lot of people who were never trained to practice in the emergency medicine who were leaving, who are often being replaced by residency trained people. So that was not good data. But now we have good data from the steady state, and the attrition rate from emergency medicine seems to be about 1.5% to 1.7% per annum. That attrition rate across the whole specialty, which is less than other specialties on average, probably because of job satisfaction and a variety of other things, that attrition rate is not evenly spread out across the career. So it's as high as 5 or 6% in the first 5 years of practice. And again, people who got trained in emergency medicine, chose it, got out there and realized, whoa, I made a mistake. This is not for me. And then there's clearly a survivor group. When you look at people who are in emergency medicine 30 years out, it's interesting. You'd think the attrition rate must go up. They're getting ready to, no, it's 1% in that group. And then it goes up again at around 35 years. But there's from 25 to 35 years in practice is the lowest attrition rate. These are people who've gotten comfortable with their work, have adjusted their schedules, have gotten to a place they can live with, and their attrition rate is actually low. Low. I find that fascinating stuff. There's been a bunch of work, not good work, to ask when we're exhausted and burned out, do we make more medical errors? And we did the driving study with people with the complex driving test that showed that after 6 night shifts, they can't drive home. I think it's pretty apparent that if you're exhausted, you're going to make mistakes. But the things that they've looked at, some of them are here, most of them are in the database. For example, they've looked at, in the middle of nights, do you have worse recognition of a STEMI? No, they couldn't find it. Do you have worse performance of X or Y procedure? No, they couldn't find it. But that doesn't mean there's not worse global performance. I think we all know that. I think we know our productivity goes down. How many of you have taken a pass on from a colleague at night who passes on to you 8 bellies, CT abdomen pelvis pending? Have you been there? That is complete intellectual surrender at the end of a night shift. Somewhere around 6 o'clock, that person just went, I can't figure it. Just to get some labs, it's the CTs, and I'll try and squeak out under the door. You know, and they're actually very unhappy if during pass on you go, oh, it looks like that CT is back. They're like, I don't want to know the answer. I don't want to have to figure it out. They're done. They're done. They're done. So we've looked at the ability to call STEMI, no change. Overall mortality change, no change. Critical procedures, RSI, no change. And people have offered these up to say, see, nights aren't that bad. But I just think that's just not the case. I think globally there is clearly performance issues that come up. So I'm going to end there. There are a bunch of other papers in here. What else did I want to get to here? There's some final conclusions, and I'll just kind of walk through those. We'll walk through that last page on page 13. Physician suicide is higher than the general population, and physicians frequently self-treat and don't seek resources because of stigmatization. Barriers to seeking mental health include, and they're listed there for you, we went over them. Physician stress and burnout are high in emergency medicine, but I would add to that third statement, but so is job satisfaction, and attrition rates are low overall, lower than other specialties. Despite high burnout rates in emergency medicine, career satisfaction rates are relatively high. That's 4. 5, physician burnout can impact physicians' negativity on both a personal and professional level. I have no doubt that that's true. We didn't talk about that. That's when you start getting short-tempered with patients. Your interpersonal skills go down. You snap at a consultant or a nurse. All of those are bad, or your APP. All of those, everyone knows all about that. I think you've all probably seen it or experienced it. Fear of making mistakes is a substantial driver of ED stress, and that's why B+ students rather than A+ students belong in emergency medicine, and that's why tolerance of uncertainty and resiliency are really important aspects of emergency medicine. I don't think we spend enough time teaching residents how to deal with uncertainty and how we play the odds every day. Remember, emergency medicine, and this is kind of an important concept, the differential diagnosis in emergency medicine is different from everyone else's differential diagnosis. That's true, I'm going to offer to you. It's never really been proven, but I'm going to just say, go with me for a second. And the reason is because if you go onto an internal medicine ward, and they do, tell us the differential, sir, right? You would list the top, given 3 or 4 symptoms, this is the most common. This is the next most common, and you would work your way through. That would be a frequentist approach to the cardinal symptoms. It's all statistics. But in emergency medicine, we have to mix that frequentist approach with a balanced smattering of worst first, right? The whole worst first approach. PE and aortic dissection aren't the most common things, but they are often the worst thing. And how to balance this worst first approach with the frequentist approach is one of the biggest challenges to teach people in emergency medicine. How do you do that? When does that worst first thing reach the threshold that you need to chase it? And we all know people who we think of as incessant zebra chasers on our shifts that don't have the right balance. They haven't got enough common sense or enough comfort with uncertainty to let that zebra go. We're not chasing. Now, you can't never chase zebras, but you certainly can't always chase them. I had a resident, we graduated, super smart resident, #1 in the country on the in-service exam. Graduated from our program, lost his first job. Why? Because he was Dr. PE. That's what they called him. The nurses called him that. He's like, there he goes, chasing another PE. They were like, they were trying to do things like, we lost the D-dimer. Do you really want it? You know, it's like, please stop chasing the D-dimer. Dear God. And then 8, physician coping strategies and organizations and leadership and balancing your life are all important in playing a role in burnout. And I think that fact that we've pivoted and are paying a lot more attention to this are really good things for us all. And I would tell you to do as I say, not as I do, because I'm working too hard.